Hi, and welcome to this concluding panel discussion. During this course, you have met different aspects of antibiotic resistance, and we will discuss some of these today. With us today, we have Francesco Ciabuschi, Stefan Swartling Peterson, Otto Cars, and Diarmaid Hughes. And first of all, I would like to ask you about the increased level of awareness that we've seen today last years. What do you think? Is it actually doing any good, or will it just get worse? What do you think, Stefan?
Well, I think it's a nice start if people are aware, but I think awareness is not evenly spread over the world. And with focusing on low and middle income countries, as I tend to do, I think things are getting worse. One, we don't know the real status, but indications are that we actually have weak health systems, we have irrational use of antibiotics, and we have challenges from things like malaria elimination, where the existence of diagnostics actually push up antibiotic use when the malaria test is negative.
Great. I'm going to stop you there. And because Otto, I wanted to ask you, do you agree?
Well, I agree. I mean, the awareness is increasing, but it is not at the level it should be. Not even with politicians. I mean, the issue is still not perceived as a crisis, not perceived as a disease, because it's not disease. It is something that undermines many important treatments. It's a long way to get the crisis awareness. On the other hand, some things are happening, and it has clearly been a much better political momentum, but been far from there.
Okay. Francesco, what do you think?
I certainly agree with my colleagues. Anyway, on a more positive note, I would like to say that actually companies recently has been starting to come closer to the problem. Very recently, they also signed a document at Davos by stating that they want to engage again. Now, obviously, from a statement to the facts, there is still a lot to be seen, but I am positive that things will happen in the coming years.
Yes. Okay. Diarmaid, what do you
Well,
think?
in general, I agree with everything they have said, but I'll be a little bit more positive. I think there is a lot of research and development in the early stages. The downside is it might be 10 or 20 years before we see the positive benefits. So I think, in summary, it probably will get worse, but hopefully it will get better in the longer term.
Yeah.
So.
Okay, thank you. But it sounds good anyway. So first, I would like to ask you, Otto. Do you think it's acceptable to not give the best available treatment, antibiotics treatment, to patients today to preserve them for the future generations to come?
Well, that's a really broad question.
Yes,
I'll try to respond to it quite shortly. But I think if we really believe that the antibiotics is a scarce resource, maybe even a non-renewable resource, we really need to take responsibility to balance the needs for this generation and the future generations. So I think in that respect, the answer is yes. We need to reserve this for the patients that really need it. And having said that, all patients in the world that need it should have it. So it's an equitable issue as well. But I think we're already doing this. I mean, it's very easy to be an infectious disease doctor if you give the latest treatment to every patient that might have a resistant infection. We don't do that.
No.
We do some kind of analysis, we assess risk factors, and I think that process needs to be strengthened to guide the prescriber in the future to really try to define which patients that really should have the latest drugs and where the risks are the major risk for having a multi-resistant infection, for example. But I think it also falls back really on the lack of diagnostics.
Yes.
Because and I think that will improve the situation and make it less difficult. The diagnosis will come and that will help. But having said that, that will not be. We will always have to guess somehow, and I think the responsibility for the prescriber is also to adjust the therapy as soon as the bacterial diagnosis is clear.
Yeah.
Okay.
But I would just like to ask you another question. It's maybe like in Sweden and Norway and for those kind of countries, because as a mother of small children, and I always have a bit of stress of time and money to stay at home, and then you tend to go to the doctor and say, I want antibiotics because it gives me 3 days. I will be back to work, or I can deliver the kids in kindergarten. But how should we change these norms and these values that we have? Because I think that's also one of the problems. Do you agree?
Again, it's difficult. I mean, we need to discuss this from different perspectives, high-income countries and low-income countries. We will come to that later. But I think it's really a long process to change understanding, knowledge, and behavior. And I think one side shortcut to that might be that to make people aware that we are carrying these bacteria in our normal flora, what we now call the microbiome, and we change that microbiome every time we use an antibiotic. And later on in life, you may get sick from your own bacteria. So it's not only for the next generation, it's also for your own sake.
Yes.
And I think that argument has been helpful here in this country.
Yes.
It could be also useful other places.
Yes. Is there someone who wants to comment on this?
No, certainly I don't think it's acceptable to withhold antibiotics from people who use them, but it becomes a question of what is best. And best is the most appropriate antibiotic, which ought to be effective. So with that qualification, yes.
And
I agree completely. I think it's important to realize that best is effective. Best isn't necessarily the latest or the newest. And the patient may not need the very latest antibiotic, and especially if we have diagnosis to guide therapy.
That's interesting. I would like to ask you now, Diarmaid, because in the course you talked about the pipelines of antibiotics that is almost running dry. And is the development of new antibiotics the only way to go? Should we broaden our minds and think otherwise, or where should we go?
Well, simple answer is yes. The pipeline, firstly, the pipeline is effectively dry at the moment, but there is a lot of early and middle stage research and development going on. So hopefully there will be new antibiotics coming online. But all of the important large companies, many small companies and many academics are researching alternatives. So there's a lot of research going on into antivirulence, into phage therapy, into monoclonal antibodies, etc., etc. So alternatives are being investigated.
Yeah.
Yeah.
So
Yes.
Yeah.
Because I think that's absolutely another way forward, and I think the collaboration between scientists should be strengthened in all these other areas as well, as you mentioned. But I think that the usefulness of those technologies will also be dependent on rapid diagnostics, because they are more targeted towards single pathogens, and antibiotics are broad spectrum, so to say. So if we can couple those technologies with diagnostics, that would really be another way forward to use antibiotics only for where they are really mostly needed.
So you use the word alternative as well. I mean, these are alternatives to direct-acting antibiotics, but they're not alternatives in the sense that you would stop using antibiotics and switch to something else. I think the value may be that we have many different alternatives, and that will have a benefit of possibly reducing the pressure to use antibiotics as often, which will have benefits on resistance selection and so on. But as Otto says, diagnostics play a big part here.
yes. Francesco, you had a comment.
Yes, I would like to add, because I really agree with what was just said about the fact that there are no alternatives. Everything has, to come forward, to move forward. I would like to point out that though this is true and my belief, we have very different mechanisms and business models around the different alternative treatments or even diagnostics, as Otto was saying. So I would like to point out that this has to be aware also for how financing has to be spread and how incentives has to be created in the different areas.
And with one last caveat.
Yes.
We have research going on into many of these alternatives. What we don't have is any proven clinical examples. So there is a danger, real danger, that some of these will not work in practice regardless of economic models. But we have to try.
Yes, we have to try. Yeah. It's interesting that you say so, because in your part of the course you talked about public-private partnerships, and it's like one of the models that is always rising up as one of the most. Is this the only way to go, or should we look at other alternatives regarding the financial? Because it is a problem with antibiotics, because you want someone to put in money for a medicine or some treatment that you would like to put on the shelf and only use in emergencies.
Another broad question. I'll try to give some hints, because the discussion is ongoing, has been ongoing, and certainly will take up a lot of the efforts in the future. There are many suggestions. Currently, I'm involved also in a project which evaluates many different models, mechanisms that should incentivate from behind, push mechanism from the research part, for instance, because if we don't have more research, more human resource involved in the discovery up front, then we will have no leads and no compounds to bring forward. So we need to think in a very systemic way. There are mechanisms that could be used in the beginning of the value chain. There are mechanisms that will instead pool more what already exists and is stuck somewhere, forgotten in the pipeline, because it's not maybe deemed to be worth developing, or maybe is something that is a second choice compared to the investment currently that a company may be willing to do. So we need to set different mechanisms so that overall, they will work in pushing forward both discovery of new, and when I say that, I would like to stress that we need new classes. So we need real discovery, real breakthrough innovation, while certainly is also worth bringing forward what already exists, and therefore some more downhill type of mechanism, some more pull factors. And said that, I want to be brief but still clear. What is crucial to me is how you combine this mechanism. Because certainly you don't solve the problem with one mechanism. There are so many differences also between the countries. We have the more wealthy countries, and also among them the legislation, reimbursement, the hospitals, they work all in different ways. But also we have all the problems that come from the poorer countries. So there is a need for tailor making mechanism and position them in the right setting with the institutional context. And this is difficult. So there might be also a combination that are not so positive. So we need to think through what works uphill, downhill in this value chain, and my final point, most importantly, mechanisms that guarantee better access and better stewardship. Otherwise, we are working for just making the problem even bigger in the future.
Yes. But that, yeah.
Well, can I
Yes.
just add to that? I think you mentioned before that in Davos at the World Economic Forum, there is some 80 plus pharmaceutical companies are now indicating that they want to come on board again. But there is not much in the pipeline for them to work with. So I think the real major bottleneck is really to get a larger group of global scientists together. There is a really weak research infrastructure, although the positive science is coming. I think it must be much bigger. That's the entry point, to have something to drive through all this development pipeline.
Absolutely.
Yeah.
And I may add also that there is a clear difference between, I'm still speaking from the business perspective, those companies that declare they are interested in contributing, although they are looking and watching for what type of mechanism may come in help, and those that are not yet involved. And we need to think about those as well. What can trigger new entrants? Because we need really cooperative efforts. We need to tackle this problem from all possible sides.
That's interesting, because the world is also a different place, and it is actually a question about access and excess, because some have a lot and use it a lot, and some don't even have access to it. And Stefan, I was going to ask you, how can you argue to spend money on antibiotic resistance in a low-income country that struggles with other problems as well? Because they could have the basic things like sanitation and clean water. So
I think the argument should be put differently. In many low-income countries, the total health expenditure per capita is about $50. And at least half of that comes from out of pocket, from patients themselves and from their parents. Many of these sick ones are kids. So the question is value for money and quality of care, because antibiotics are available everywhere and they're being used. The question is, are parents getting value for money? Are patients getting quality of care? I think indications are that there are still more people dying from lack of access to antibiotics than there are dying from resistance in low-income countries today. So I think with the focus on quality of care, we shall also achieve what we want to do with rational drug use and antibiotic resistance.
Yes, absolutely. I think we need to do that, but also what can be done in those contexts, but also in everywhere in the world, is to change what you said in the beginning, change behavior and social norms. And I think the knowledge and understanding of what antibiotics are used for, should be used for in low-income countries, and is very low. So I think we can do a lot of good things by driving knowledge forward and making patients not demand and not going to buy the antibiotics when there's no need.
Certainly, but I think some of those incentive mechanisms, they apply to parents. Obviously, you want to be sure, and you might want to be, you might not want to drop your kids at kindergarten like you, Jessica, but you want to go and be a farmer, and you can't spend the whole day going 5 kilometers to the health center, so you go to the private sector and buy 50 shillings worth of drugs. So the question is, how can we increase access to effective antibiotics in the right dose at the right time, etc.? And that, I think, will take interventions both on the so-called supply side, public as well as private, and on the demand side, knowledgeable consumers.
But I was wondering, some places you would need clean water, for example, and starting by that, should you rather use money on that in these parts of the world where this is the bigger problem? Because children will also die from that, and you will also spread resistant bacteria from lack of sewage. So how should you argue when you say we are all responsible because it's a global problem? Are any?
I think we're not in a position to make, we're only to a limited extent to make those decisions with public funds that we put in, because parents make decisions for their children and they spend their money accordingly. And having a sick kid is a very compelling situation.
Yes, it is.
If I can come in here, I don't think these things are necessarily in opposition to each other, sanitation versus antibiotics. If the aim, as Stefan is saying, is parents want their children not to die of bacterial infections or viral infections. If you look at the history of the Western world, in the early part of the 20th century, there was a huge drop in mortality, which is largely associated with improved sanitation, clean water, not with the introduction of antibiotics. Antibiotics are very helpful, very useful to individuals, but for society as a whole, the biggest improvement can probably come from improvements in sanitation. And I think this is an issue for those countries, and maybe world organizations should be helping them, because not only will it benefit their people, but it will benefit global antibiotic usage and resistance and effectiveness, again by reducing the pressure to use as much antibiotics as we use.
Sure, I mean, prevention is key, and of course a lot of hospital outbreaks where children die is are caused by lack of sanitation, lack of basic hygiene principles, and lack of alcoholic hand rub or soap. So I mean, those basic things is really important.
But I think we haven't started making all of those huge public campaigns. If I look back at my life in Sweden, I've sort of grown up listening to people, I don't know if it's been Otto all the time, has it, saying that you should take my antibiotics properly. And that all of that massive investment in public education has yet to happen around the world.
Yes, of course. But maybe we should raise awareness about that as well then. I was wondering, in your opinion, what would be the most important action point right now? Let's start with you, Otto. What do you think?
I was hoping to get
Okay, we can
later on.
someone.
No, I can start for sure. It's because it's a really difficult question.
Yes,
Again,
I know.
you can't only do one thing.
I know.
But I think, though, that I've been at numerous meetings over many years, and I think what comes up all the time has come up all the time. If we just had the point-of-care diagnostics, if we just had the diagnostics, we would be much better off to pinpoint the patients that really need the drugs. And I think that development line has been standing still for too long. It's coming along now, but I think that should be a real focus. That will help a lot, especially in the low-income settings. where there is lack of laboratory facilities and so forth. So diagnostics and, of course, new treatments is key. And I think they need to be upfront, and then we have to do all the other things in parallel.
Okay. Stefan, you wanted to?
I think we must avoid making things worse. I think there's an obvious risk that we in high-income countries will lock up the antibiotics for people in low-income countries and make access worse. So the fact that there is excess and irrational use must not really punish access for the most vulnerable in the world. So I think primum est non nocere, first is not to harm. So let's not make things worse for poor people as we attempt to address this.
Francesco, do you have a
I think that
major point?
to add on, what I would like to underline is the fact that right now we need to implement the mechanism so that we can support basic research and the SMEs involved in the first stages of development and bring back more pharma's, big pharma's investments. We need to implement mechanism. We need to be out there and test new ways of collaborating, sharing risks and costs, so that we have some new antibiotics.
I will agree with all of this and add on one extra thing, which is I think we have to realize this is a never-ending game. We have to have continuous pipeline of investment because, you know, we cannot risk the issue that came up a couple of decades ago where people simply left the game, problems arose, now we're trying to pick up the pieces. So investment, sustainable economic models, research, new therapies, alternatives, everything, but it has to be ongoing.
Yes, and I think we also have to be aware that the bacteria have been around here from ages. I mean, we have been here a few seconds of the bacteria's lifetime, and we should probably be a bit aware of what we do to them and how we react to them to save our future. I think this was really interesting, and I would like to final up with the final question. Diarmaid, where do you think we are in like 50 years from now?
Well, if we don't develop sustainable models to continue research and development, I think we'll be in very big trouble. So
yes.
It's pessimistic, but
It's probably
I hope we make the right choices.
Yes.
So.
Otto, what do you think?
I think it was the Nobel laureate Niels Bohr who said predictions are always difficult, especially about the future. So I think it's difficult to say. I think climate change may have significantly changed infectious disease epidemiology. We don't know what there is heading, what that will entail for this problem. But I think, as was said, we can never solve the problem. We can only get back to balance. And I really think that we will have some more balance between innovation, availability of drugs, and the balanced rational use, and also new technologies like nanotechnology, microbiome engineering, genetics will probably help a lot.
Right
Stefan?
now, we focus on individual diseases, or as in this case, a class of drugs. 50 years from now, I want to see us focusing on people. Be they healthy, staying healthy, prevention as we discussed, but also addressing them with the problems in an integrated manner when they're sick. As it is now, you may present as a kid with an acute febrile illness and you'll be told, good luck, you don't have malaria, congratulations, have antibiotics instead, or vice versa. We need to integrate diagnostics into clinical algorithms and solve the problems, whether they are caused by one disease and treated by one class of drugs or other. Otherwise, we'll be in a mess.
Okay. And Francesco, what do you think in 50 years?
Well, with a positive tone, I think that in 50 years we will certainly have some new antibiotics. Maybe some other problems will arise, but we will be able to tackle some of these issues. But most importantly, I wish that we will have worldwide control over the antibiotic use and distribution.
That's a good point and a very optimistic point.
Thank you.
And with that, I would like to thank you all for being here today and sharing your opinions and interest. Diarmaid, Otto, Stefan, and Francesco.